Hello, listeners. From the RSNA, this is the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath, and I am a radiologist from Dallas, Texas. In this podcast, we explore research advances and technical developments in cardiothoracic imaging through conversations with our authors, our editors, and experts in the field. Enjoy! Be in Chicago for RSNA 2022, Empowering Patients and Partners in Care, where the biggest week in radiology inspires professionals and industry partners from around the world. Be engaged with more than 400 educational courses and scientific sessions from every subspecialty. Be inspired by more than 500 exhibitors featuring their latest technology, demos, and industry presentations. Join us in person, virtually, or both. Register now at rsna.org/register. Hello, listeners, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath. On today's episode, we will be exploring a recently published original science paper in the journal. The paper is titled Feasibility of Coronary CT Angiography-Derived Left Ventricular Long-Axis Shortening as an Early Marker of Ventricular Dysfunction in TAVR. This paper comes to us from our colleagues at the Medical University of South Carolina. The lead author is Dr. Gilberto Aquino, and the senior author is Dr. Tilman Emrich. I had the pleasure of discussing the nuts and bolts of this study with Dr. Aquino and Dr. Emrich on this episode. However, before we get into that conversation, let's quickly review some background information. Transcatheter aortic valve replacement has become a worldwide staple in the arsenal against aortic stenosis. Risk stratification is imperative in the decision-making process prior to treating our patients with aortic stenosis. For this reason, many clinical and imaging-based risk stratification tools have arisen to aid in the management of these patients. This paper describes a retrospective single-center study that asks the following question. Can a novel CT-based anatomic measurement of the heart predict adverse outcomes in patients who underwent TAVR? The principal CT measurement described in the paper is left ventricular long-axis shortening, or LV-LAS for short. LAS is roughly similar to longitudinal strain in echocardiography. Briefly, to calculate the LAS, one prescribes a 4-chamber view of the heart, then measures the linear distance between the center of the mitral valve plane and the LV apex. The comparison of this distance between systole and diastole describes the LAS. A bigger negative number equates to more shortening. A smaller negative number equates to less shortening. Despite initially screening over 700 patients, only 175 patients were included in the final analysis of this study. These patients had an average age of 79, were 52% male, and had an STS-PROM of 4.0%. The long-axis shortening was measured in all of these patients on their routine pre-TAVR cardiac CTAs. Over 2 years of follow-up, the overall mortality rate was 22%. In a clinical multivariate analysis, LAS was significantly and independently predictive of mortality with a hazard ratio of 2.83. This predictive ability of LAS persisted even in patients with a normal ejection fraction. When applied to STS-PROM, adding LAS increased the predictive value from a very modest statistic of 0.64 to a slightly better, albeit still only modest, 0.71. From these data, the authors conclude that left ventricular long-axis shortening can be used independently to predict mortality in patients undergoing TAVR. So listeners, what do you think? Does this study answer the intended question regarding risk prediction in TAVR? Does LAS deserve a spot in clinical workflow of our patients with aortic stenosis? To address these questions and more, let's now jump into my conversation with the lead and senior authors of the paper. Hello and welcome back, listeners. I have with me now Dr. Gilberto Aquino and Dr. Tilman Emrich, the lead and senior authors of our featured paper. As a reminder to our listeners, the title of our featured paper is as follows: Feasibility of Coronary CT Angiography Derived Left Ventricular Long Axis Shortening as an Early Marker of Ventricular Dysfunction in TAVR. Gentlemen, welcome onto the podcast.
Thank you for having us.
Thank you for having us.
Of course. Before we begin talking about the paper itself, let's learn a bit about both of you. Where are you practicing currently, and what are your academic areas of interest? Gilberto, why don't we start with you?
So right now, I started residency training a couple of months ago. Right now, I'm doing my internal medicine year, followed by 4 years of radiology, as is required in the United States. I'm doing it at SUNY Upstate in Syracuse, New York. I'll be doing all 5 years here.
Excellent. And Dr. Emrich?
Yeah, I'm, as my terrible accent tells everyone, I'm originally from Germany. So I studied human medicine in Mainz, a wonderful, nice town there, and also spent my radiology residency there. In 2020, I took a big step over the ocean and joined Joe Schöpf's group in the Medical University of South Carolina. And I've been there for the last 2 years, now acting as an adjunct assistant professor of radiology, but also moved back to Germany physically to develop and initiate a group in my old university focusing on cardiovascular imaging. From my background, I started to do cardiovascular imaging very early in my residency, and also on a scientific purpose, or my academic research was always cardiovascular imaging. Coming originally from CMR, and while moving to Charleston, I then moved directly into more CT and recently a lot of photon counting CT. So that's where I'm coming from.
Excellent. Well, once again, thank you both for joining us on the podcast. And now that we have an idea as to where you both are from and what your areas of interest are, want to get a little more background on the information that we're going to present from your paper. So before discussing some of that, let's get an idea as to some of the current tools that we use in TAVR with regards to peri-procedural risk assessment. Some examples might be the Society of Thoracic Surgery, PROM, or other types of risk scoring. Gilly, would you mind starting us with a brief discussion as to what these clinical risk assessment tools may be and how they may perform?
Yes, of course. So primarily we have two scores that are the ones used clinically, and those are the STS-PROM, as you mentioned. But we also have the Euro score that is mostly being used in Europe. So for the Euro score, for example, this was first published in the late 90s, and it was later recalibrated sometime around 2012. And now it is named Euroscore 2. Now, the STS-PROM was first developed in the early 2000s in the United States and has been recalibrated and updated continuously over time. And the latest version is the version 4.2. So these are the tools that are currently used every day in order to make decisions regarding the appropriate therapy for aortic stenosis, the appropriate surgery for aortic stenosis. And the Euroscore 2, for example, it includes a total of 18 questions, while the STS score is a little longer and has more than 50 questions that you have to answer in a calculator online that is available to everyone. All of these questions are regarding patient demographics, patient past medical history, social history, medication history, echocardiographic findings, among other findings. And all of this is combined, and then it throws you out a final score that is used to risk stratify patients. And by risk stratify patients, I mean, for example, in terms of the STS, I'm not sure about the Euro score in this aspect, but for the STS, those with an STS below 4% are deemed as low risk for mortality after TAVR. Those between 4 and 8% are deemed as intermediate risk, and those with an STS above 8% are deemed as high risk for mortality after TAVR. And these are the risk groups that have been used for many, many years. And even in if we go into the partner trials, which are the main trials that have validated the safety and benefit of TAVR, all of these trials have used the STS and the Euro score as part of their risk stratification tools.
Yeah, Gilberto, that's a great review of what we've used previously as clinical risk assessment tools prior to selection of patients for TAVR. Can we comment a bit on how these tools have actually performed with regards to actual patient outcomes? Tillman, would you be able to help us with that?
Sure, yeah. I talked to my favorite cardiac surgeon, who is technically my wife again. So I had like a first hand information. It's very interesting, I think. So first of all, we have to understand where these scores are coming from, right? And these are scores that are not perfectly tied to TAVR patients. That's like a cardiac surgery risk score that was developed. And for instance, the Euroscore actually was designed by a collaboration between Samar Nasha from Pepworth in UK, which actually I had like, I think 3 months of my student time with. Very nice that I spent time with this brilliant guy. And they just focused on so many things to calculate risk for such a diverse patient population. And now, if you look after over 20 years how this initial score performs, then we clearly see that in real life, the old scores from the 90s or the beginning of the century, they are not as realistic anymore. And as Gilberto mentioned, there's a constant development of these things. For example, the Euroscore is currently recruiting centers to have more data for Euroscore 3, and STS is also constantly updating. So if we then take a look at the real world data, I think everybody sees that they are not perfect, but they are pretty okay-ish, I would say, if you look at the overall patients. Yeah. But they have been validated in so many studies and different populations from Western countries to, let's say, there is a nice study from Brazil that looks at all the risk scores and how they perform. And in the end, they perform good to okay, but there's still room for improvement for several factors. So I think that's the point where we also start picking this up to see that there are patients who have very high risk by their score, but after 2 years, they're perfectly fine. So there's clearly the room for improvement of these scores in real life.
Within and outside of the structural cardiology space, I think many of our listeners are aware that clinical risk assessment tools are good, but not great. They help with initial management strategies, but they may not be as predictive of downstream events as we would like. And that's kind of where a lot of the advent of imaging biomarkers have come into play. Some of them, at least in the TAVR space, that a lot of interest has been around is with regards to longitudinal strain derived from echocardiography. Could we discuss some of the benefits of longitudinal strain as well as the potential downsides of using it?
Coming from CMR back then, we were always amazed by the echo guys doing strain. And first of all, I think it's interesting to understand what strain is. Strain is a parameter that looks at myocardial deformation. And technically, if you look at the cardiac motion, you can analyze different motion patterns. And I think for TAVR or in this population and coming from echo, the most commonly used is the longitudinal strain, so the longitudinal deformation that just looks how much the heart squeezes if you look from the base to the apex. And it's originally, there have been many solutions for this technically coming from very, very long time where people sutured metallic markers on the heart and just looked at it, how it contracts and how this contraction pattern changed. But nowadays with echo and the rise of this speckle tracking technique, there have been really a lot of studies investigating the potentials of strain. And why is everybody doing this? I think there are two reasons. Number one, it's relatively easy because you basically need, for example, a 4-chamber view cine image or echo cine image. This is something which is routinely acquired for every patient who gets an echocardiography. And number two, it's a post-processing technique. So once you have the data acquired, you can apply a post-processing to it. And the beauty of it is that it's, in contrast to the ejection fraction, not only a marker of the global function or overall function, but it already starts detecting changes in the ventricle even when the global ejection fraction is still normal. That means we have a more sensitive tool to detect kind of disturbances in motion patterns and deformation in the heart. And for me, when I first saw that, it was absolutely amazing to see, for example, patients undergoing chemotherapy, to see that the ejection fraction is still normal, but the longitudinal strain is degrading step by step until at a certain time point also ejection fraction reduces. So I think that's one of the benefits of that. It's kind of simple post-processing. The downside is it has to be standardized. And I think Echo is doing a pretty good job at the moment to have that standardized. In the CMR world, I think that was the next frontier where people start using strain imaging and feature tracking strain. We have a lot of problems in standardizing. So meaning you take one patient and put him in 3 different MR machines from 3 different vendors, and then potentially apply 3 different strain softwares to it, you most likely get different values. And that means that it's hard to compare in between centers and have real cutoffs that are not derived for your machine, for your software solution. I think in Echo it gets a little bit better, but in CMR it's still a problem, and that's also true for CT. So it takes time to have good normal values, and it's of course a post-processing, so you have to have somebody who does that after the examination.
Tillman, a lot of your discussion just now focused around echocardiographic and cardiac MR-based solutions for evaluating strain. Gilly, can you talk about how we can potentially apply that information to CT data, which we routinely collect in the evaluation of our pre-procedural patients with severe aortic stenosis, potentially going to undergo a TAVR?
Yes, exactly. And that's mainly where we got our inspiration from, is seeing this type of measurements in echo and CMR and thinking whether we could translate this into CT. And mainly there was a paper, I believe, in JCMR in 2015, which took a simple measurement of longitudinal function of the ventricle, of the left ventricle in CMR. And when we saw that, and when we saw the images, we thought, okay, this is obviously just taking a 4-chamber view, right? And then taking a measurement from the middle of the mitral plane to the cardiac apex. And it had some value for them. It was for cardiomyopathy patients. And we thought, why not try this with the CT-TAVR that are already acquired? It's already here. We already have the data, and see whether it has some degree of significance to predict mortality after TAVR or not. And that is basically where we got the idea to develop and to move on with this project and to assess, again, the feasibility of longitudinal shortening and its predictive value in TAVR patients.
I wanted to clarify something for this part, Gilly, for our listeners. The measurement that you're describing on CT, the distance difference between the mitral valve plane and the cardiac apex, is different than the way in which our echocardiography colleagues would evaluate a longitudinal strain, and our MR colleagues would evaluate feature tracking based strain. Is that correct?
It is different because those type of measurements are more complicated, more complex, let's say. So it's not quite like, even we have CT global longitudinal strain as well. But this type of measurement take more measurements or more variables along the whole ventricle. But when we're talking about the measurement that we use about longitudinal shortening, and you think of it just 2 simple lines, 2 simple distances, it is different than the spectrum tracking and echo and more complex measurements in CMR. But then that previous study that we talked about before, they also took basically a simple longitudinal measurement in CMR and found some degree of significance with it. So that's why we thought, okay, why not do this simple thing and translate it into CT and see whether we could do something about it, and whether we can find a relationship with mortality in TAVR populations.
And also, if we dig a little bit into the technical principle of speckle tracking and also feature tracking, it's basically that these techniques rely on that they track several points in the myocardium or in a region of interest over the cardiac cycle. So it's and then derived from all this information from several segments, then they calculate an average which represents the global longitudinal strain, for instance. I played around with feature tracking in CT. It's feasible. You can do that. You basically have a point, a contour, and you follow this point over the time. That it works similar to what you can do in CMR. However, what we wanted to do is we want to take a very simple approach, which has been published by Riffel et al. Before, that already shows a very high correlation to this global longitudinal strain by feature tracking. So this is the point. We don't do a really sophisticated stuff, but a very simple measurement that can be obtained without any additional software that you have to buy or install. The post-processing time of these images is super fast. You have to basically draw 2 lines, and you get a value out of it, a quantitative value out of it, that is not as sophisticated as a longitudinal strain, but it comes very close to that. And that's where we thought the beauty is in, because we wanted to do something simple and then apply it to CT and get a significant information out of that.
Excellent. So not only is it simple in terms of the manner by which the measurement can be made, but also robust relative to other data that we've acquired from other imaging modalities, strain, for example, from echocardiography. With regards to some of that elegance, the simplicity, can we talk now about the variability in the measurements, both between observers and potentially between the same observer?
Yes. So in our study, for example, the inter-observer reproducibility was of 0.90, had an intra-class correlation coefficient of 0.90, while the intra-observer reproducibility had an ICC of 0.92. Both of these ICCs are considered as excellent. So we do believe that this measurement of LV LAS is highly reproducible between observers and between same observers. Now, something that I want to point out, because it's something that came up in the review process, is that at least for inter-observer reproducibility, both readers did it on successive fashion. So the first reader obtained the 4-chamber view, did the measurement, and then the second reader took the measurements right after. So we do not consider this as a huge limitation, given that, for example, if you see CMR or if you look at echo, where the technologists take a 4-chamber view and that is what gets into the PACS system and gets processed by everyone else, it's basically the same thing. As long as you follow a standardized approach to obtain the 4-chamber view, which is what we did. There's an academic radiology paper from 2007 pointing out the steps to obtain a 4-chamber view, and that is exactly what we use to obtain those views and then proceed with the measurements. And something that adds to our paper as well is the intra-observer reproducibility, because this was not done in a successive fashion, but rather 4 months apart. To do the same measurements 4 months apart and obtain an ICC of 0.92 is still pretty good, and shows that these measurements, as long as we follow a standardized approach, should be reproducible between institutions and between observers.
Excellent. I think that you've well demonstrated that the technique is elegant in terms of how it's easy to acquire, and also robust enough that multiple different observers can obtain a very similar value, and it is robust relative to other standards that some of our imagers may be familiar with. Let's now get into your study specifically. Your study evaluates this exact CT-derived longitudinal shortening, as well as a few other metrics, in a retrospective fashion at a single center. I see that you've initially screened just over 750 patients for analysis, but eventually only 175 were included in the final analysis. Could you speak to why so many patients were excluded, or perhaps phrased another way, why only a few patients were included?
Yeah, so for being included in the study, there are basically 2 entry points that you have to have as a patient. The first one was relatively easy. That was, you need to have a retrospectively gated cardiac CT with a systolic and diastolic image to obtain the value. That was not the biggest problem in our cohort, but the second one, we need to have outcome data. And the outcome data, that was a huge limitation for our retrospective evaluation, because we were not able to access data from the patient, which was, I think, a little bit influenced by how our center or our institution had a follow-up strategy. So the patient just came back for a 1 month follow-up. But for a lot of patients, we had no information what happened to them after the first 30 days. And that is clearly a limitation of our work, where we see that this could introduce selection bias because we just have the information of people that have been around for or have been followed up by roughly 2 years. And of course, we are working on that. So what we built on of this experience is we generated kind of a registry also with a couple of other centers, just acquire more broad data to look into.
And this is understandable with a retrospective analysis that some patients, because they're not part of, say, a large prospective trial, will be lost to either follow-up or whatever it may be. That said, with regards to those 175 included patients, can we evaluate the demographics of their disease relative to other larger TAVR registries that may be out there?
Yeah, we can. And the fact is that it is pretty funny because, for example, the median STS in our population was of 4.0% exactly, which is right in the middle between low and intermediate risk, like we talked before. And when you look, for example, at the partner trials, you have the partner 2 dealing with intermediate risk patients, and you have the partner 3 with low risk patients. And you look at those two studies and you look at ours, and the demographics are our demographics are right in the middle between those two studies, and that it makes sense because if you have an STS, a median STS of 4.0, you're right in the middle between those risk groups. So you'll take a look at all the tables and see that the frequencies and the means and medians of our population are right between those two studies. Sometimes it's more similar to the partner 2, sometimes it's more similar to the partner 3, and sometimes it's right in the middle between the two. So that is what you can see when you see the demographics in our study.
Perfect. I think that'll help give our listeners some context as to what patient population was evaluated in the final analysis of your study. Let's then move to our results. What happened with regards to the evaluation of longitudinal shortening of the left ventricle and eventual outcomes in terms of any correlations you may be able to derive?
Yes, so we found that the worse the LVLAS, the higher chance a patient had of dying during or after TAVR. The cutoff that we arrived to was negative 9%. Those with the worst LVLAS had approximately 3 times more likelihood to die sooner than those with a better LVLAS in our study.
Got it. And does that almost inverse correlation between LVLAS and mortality mimic what we've seen in the echocardiography literature with regards to longitudinal strain?
Yes, for sure. And you'll see that the worse the strain, then the more likely patients are to die. Now, the cutoff itself is different, and we have put the focus on that. But we need to remember that the cutoff we arrive to is fitted to our population and to our study, and should not be the cutoff that we suggest in the future necessarily before we go on and prove that is the right cutoff in prospective multi-center trials. So even in echo global longitudinal strain, for example, they have different cutoffs of negative 16, negative 17, sometimes it's negative 15%. So you can see that the cutoffs are different between one modality and another, but the right or correct cutoff will only be known after multiple populations are assessed and this cutoff is validated in an outside set of patients.
I think our study adds, let's say, another point of proof that this analysis of deformation, it may be speckle tracking, it may be feature tracking, it may be feature tracking applied on CT, or a simple measurement like we did with the left with the shortening. Every study basically has shown that this is a superior marker than just simply looking at global ejection fraction, number one. number two, it also works in patients that have preserved ejection fraction. So even if you have ejection fraction over 50% and you are regarded as a completely normal patient with a high-grade aortic stenosis, you will have a benefit of measuring any kind of disc deformation analysis. So we are perfectly matching in that shape. And I think the beauty also in our study was that it was not only prognostic as a parameter itself, but if we compared it to several other parameters that we evaluated. We did multivariable Cox regressions and compared it to the STS-PROM, and both it was an incremental independent association with mortality and this simple and beautiful, easy to obtain parameter. So I think the question is independent which modality you use. The measurement of a deformation parameter makes sense for prognostication in TAVR patients. That's my takeaway from all that.
Excellent. So I think our discussion thus far is demonstrating that LV shortening, left ventricular shortening measured by CT, is relatively simple to perform. It's reproducible. It's robust based on previous studies relative to what many of our imagers may know in the strain world. And in this current analysis, it is predictive of outcomes, and it does have an incremental benefit over, say, clinical risk tools alone. My question for you then is, do you think that the study that you performed is adequately powered, and did we have a long enough follow-up to make the claims about the predictive value with confidence? And if not, what more would you like to see before we can make those claims with confidence about this new CT metric?
So we do believe that it is adequately powered, and even though we did not perform a power analysis before doing the study, we did a post hoc analysis, which is obviously not what you prefer. We found that it has between 80 to 90% power when doing power calculations. So if we go above that 80% power that everybody wants, then we see that it is adequately powered. Now, regarding the follow-up, we had a maximum of 2 years of follow-up, and this is not different than what we saw in current literature. Many studies didn't, even with TAVR, they take 1 year follow-up or 2 years follow-up. It's very rare to find one that goes beyond 2 years. And the reason for that is that you want whatever parameter you're assessing, you want it to see whether it can predict at 30 days, a year, 2 years, but beyond 2 years, at 3, 4, 5 years, you don't know if what happens after that 2 year timeline is really because of that parameter that you're trying to assess. Again, and this is especially important in TAVR studies because remember that we're dealing with an old population. So, for example, the mean age in our study was of 79, 80 years. Many of these patients might die because of other comorbidities and not necessarily because of aortic stenosis or TAVR at all. So if the longer you go beyond that 2 year point, the most likely there are confounding factors that may confuse or confound the results of your study.
Tillman, do you think that LV shortening by CT is ready for clinical prime time? Should we start using it in our clinical practice?
I mean, from the technical perspective, I think it's easy to do. It's robust, it's reproducible, so we could do that. But I think we are basically one of the first groups that tried that for an academic purpose on a single center, on a single ventilator. So before we can recommend to do that in a clinical everyday scale, I think we need to have much larger evidence, and we also need to make sure that it does not only work for the scanner that we used from a certain vendor on a certain TAVR protocol, for example. So I guess there's a lot of work to do, which actually from a scientific point of view, I really like, because that means we can write a couple of more papers for that. But before we implement that in everyday life, it's a little bit too early to do so. So larger multi-center prospective trials, that would be the thing that I would love to see. And in addition, I would also like to know how we actually perform against echo, CMR, and feature tracking CT, right? So we propose now a very simple method. which may be good enough, but we don't know that. If we could demonstrate that this is really similar, or at least on a level with the other more complicated post-processing solutions, then I would say, okay, this is a point to take that into clinical reality. If not, then we have to reevaluate and look what we have to do afterwards.
Excellent. And you've kind of alluded to it already, but I'm curious to know if your group is exploring new work in this particular field or in the TAVR field in general.
Absolutely. So for me, I was always wondering, when we perform a TAVR CT, then we obtain images of the whole body. And part of them, they have functional information because we acquire a CT with a cardiac cycle and images over different parts of the cardiac cycle. And I think for me personally, this information, we just use it for analyzing, and we just use it for analysis of the access route. And personally, our idea, or our big idea behind this, is that we should use potentially all available information that we get out of CT for prognostication. So that means not only looking at left ventricular shortening or right ventricular shortening or the left atrium function. We published a couple of papers of that, and there are other groups that look at calcium scoring, CT-FFR, and so on. A lot of singular parameters have been, let's say, evaluated, and all of them showed any kind of benefit in outcome prediction. However, I think where we have to go is we have to combine that into, let's say, comprehensive TAVR risk score that is built not only on clinical parameters, but on things that we get out of the CT. And this is a lot, right? So we can look at the heart, we can look at the coronary arteries. Gilberto published this wonderful radiology article about CT-FFR in radiology and outcomes. The Zurich group with calcium scoring. A lot of people have looked into the distribution of body composition in TAVR patients, visceral fat, muscle mass, bone densities, and so on and so on. These would all be parameters that could be evaluated using the TAVR CT, and then potentially help us improve. When I come up with this idea, I think everybody screams, and like if we speak to Gilberto as a resident, they will say, we don't have time for this. Who should do that? I mean, I have to do this crazy TAVR measurements and do the analyzing and measure out so many arteries. There is such no time in clinical routine to perform all these sophisticated measurements. And maybe I can pass the ball at that point to Gilberto and say, we need to find a solution for that, right?
Yeah, I mean, we do, and it's a lot. It's a lot to take in, and a lot of time for one TAVR CT. So, I mean, one thing that we're also thinking about is if we can combine all these measurements and have the help of some AI in order to get these measurements automatically, and that way we will save a lot of time and still provide patients with a good prognosis and improve patient safety and benefit. So we want to first gather whether all of these measurements together can take part of a comprehensive score. And then the next step will be whether we can get an AI to take these measurements and reliably, of course, and then be able to predict mortality after TAVR with the AI.
To spoil first results of that, which we presented in Vienna at the European Conference of Radiology last month, there is kind of a dose-like reaction if you combine different CT parameters and add them up into a risk score. So if you look at different things, if you look at the heart, if you look at the lung, if you look at the bones, at the body composition, and then add all this information together, then you get information that is simply more than analyzing. And the only thing that we now have to solve is to make it feasible, that nobody has to spend a second on this. You get it basically automatically with AI. And we need to work on that, and we need to prove that it's valid. But once again, I think a simple measurement that is technically very easy to reproduce is also something which is very nice for an AI algorithm to do and to provide an information, and without spending the valuable time of a radiologist while he's looking at the images.
I, for one, must say that I am very excited for the future Gilberto metric in TAVR scoring that synthesizes clinical data, imaging biomarkers, weights them appropriately, automatically calculates it, and gives it out in our report so that our interventionists can determine exactly what the next best steps should be for our patients. Hey, to you both, any last thoughts before we conclude?
I do have one, and it's something that we've been wondering about since the start of this project, and it's what is the clinical relevance of LVLAS, for example? Now that we're talking about this, what are we really going to change in patient management and monitoring by showing everyone that this factor is predictive of mortality? What is going to change in patient follow-up? And that is exactly where we want to go. We want to see, so right now, at least at MUSC, where the study originated, and in many institutions in the US, the normal follow-up schedule after TAVR is at 1 month, the patient has to return for a follow-up, and then at 1 year, and then yearly after that. I believe in Europe it's like this again, but maybe Tillman can chime in on that. But again, they're followed at 1 month and at 1 year. And this does not change based on anything acquired before TAVR. It's always 1 month and 1 year. So if we show that based on LVLAS, this schedule, this follow-up schedule should be changed to, for example, every 3 months or every 6 months based on the LVLAS results, then maybe we can prevent patient deaths more than we are doing right now. And it doesn't have to be as frequent as every 3 months, but if an LVLAS, let's say, is -6%, -7%, maybe we should suggest, okay, follow up at 1 month, then come back at 6, and then at 1 year. And maybe we can catch something at that 6-month follow-up that we're not catching right now, because we tell the patients come back in a year and they die within that year because whatever they had, it didn't show on the echo at 1 month, right? So this is where we're trying to go with this project, is whether we can, again, the goal is not to show shiny findings and publish these papers just to publish them, but to improve patient management and safety. This is what we're all in this for. And so if we can do that with these measurements and with this whole project, then this is something that we're definitely interested in doing. And something that I want to mention is that we need to keep an open mind, because even though all of this represents more work for radiologists, it does. We started this CT-TAVR history started somewhere. And it started by being first a retrospective study where they analyzed, Dr. Leipzig and his group analyzed that measuring the annular size was beneficial for patients. And then they moved on to a prospective multicenter trial. And as a result of that, all radiologists this is why we are doing the annular sizing, right? It's as a result from that project. So we need to keep an open mind, see what benefits patients and what doesn't benefit patients, and of course, validate externally. And when that happens, then maybe incorporate it into clinical routine.
Excellent. Tillman, any closing thoughts?
I think Gilberto said that perfectly. There's still work to do, but I'm very, very excited to be a part of this little journey and see what will change with TAVR. Now, the last 10 years, basically, we learned that TAVR is the next big thing, right? And you can apply it from high risk to low risk, and it's done frequently. I think the next 10 years will be to learn how to follow them up and how to not only successfully implant a valve, but how to take care of the patients afterwards, that they have the most benefits of this intervention. And maybe CT and CT-based risk prediction is one part of this. And I think this is a nice thought, my last ideas that I have to this topic.
Awesome. Well, this conversation has really been splendid. Thank you both so much for giving us your time and expertise. Our audience is going to absolutely love this. I can guarantee it.
Thank you for having us here.
Of course, it's our pleasure. For our listeners out there, you can find this featured paper on the Radiology Cardiothoracic Imaging Journal's website. Remember, if you like what you hear from us on the podcast, please rate, review, and subscribe to us. We will see y'all next time.